Hi everyone, today I'll be presenting a 30-year-old gentleman who came with complaints of diplopia and difficulty in hearing for the last 1 year. There was no history of surgery or headache in this patient. These are the MRI brain images. Here we are able to see there are multiple dilated and tortuous T2 hyperintense vessels which are seen in the pial surface space of the cerebellum and along the tentorium cerebelli. There is also a dilated vein of Galen which is seen here. Apart from this, we are able to see T2 hyperintensities which are seen in the left pontium brachus as well as in the right thalamus. Coronal images, again these findings are better appreciated. This is a vein of Galen. These are the multiple dilated tortuous T2 hyperintense vessels which are more clustered along the tentorium cerebelli, the superior aspect of the cerebellum rather than the inferior aspect. There is no definitive mass lesion. There is no parenchymal nidus which is made out. FLAR images show that some of these T2 hyperintensities which we saw were actually infarcts which are better appreciated in the right thalamus, right midbrain and left deep white matter of the cerebellum. There was also social hemosiderosis which was noted in the SWA or GRE images. Here we are able to see linear black lines which are seen along the folio of the cerebellum. There is also dense hemosiderin deposition which is seen along the pulvinar of the bilateral thalami. This is an MRA image. In MRA image, what we see is during the arterial phase image, that is during the arterial, we are able to see vein of Galen which is getting visualized. So in an MRA, we are not supposed to see any veins normally. Since this patient is having an abnormal finding, we are able to see the vein of Galen. So that implies that the vein of Galen is having a flow rate which is the same as the arteries in this patient. So this is a vein of Galen which is seen. Posterior to it, we are able to see a cluster of high signal intensities which is seen, which is basically the fistula, and this is supplied by the feeders from the internal maxillary artery as well as from the occipital artery. Here we can see that the occipital artery is close to the fistula, whereas the middle meningeal artery is taking a long and a distant blood supply into the fistula. But however, here we are able to see this occipital artery, the mastoid branch, is actually a transosseous branch. It is going through the skull and it is entering. Whereas when the middle meningeal artery enters into the skull, it enters through a foramen. That is the foramen of spinosum. So it is easier for the microcatheter as well as for ONYX to be injected through this longer path rather than the shorter path because of the foramen spinosum. These are called as the transosseous feeders into the fistula. Here again we are able to see all this anatomy better. This is the middle meningeal artery which is running posteriorly, and this is the level of fistula, and this is the occipital artery. This is the transosseous feeder or the mastoid branch which is going into the fistula. From the fistula we are able to see the vein of Galen and the straight sinus which is getting opacified. These are all observed in an MR angio image, suggestive of an dural AV fistula. There is no nidus which is documented here. This is a MR venogram image. In the MR venogram image, again we are able to see there is bunch of blood vessels, all dilated cortical veins of the posterior fossa which is seen. We can compare it with the anterior aspect of the MR venogram. It's all bunch of blood vessels which are running into the posterior fossa because of the fistula and because of the straight sinus. Here we are able to see the straight sinus is not going and joining the rest of the deep venous system. It is better appreciated in the cine image. So this is an isolated vein of Galen as well as a straight sinus pathology, not entering into the rest of the deep cerebral system. This is one of it has a very important clinical implication that it goes into a Borden type 3 kind of anatomy. We'll discuss about that later. So to confirm it, we did a DSA. In DSA, we are able to see this is the external carotid artery run right side. Here we are able to see this particular branch which we see. This is the middle meningeal artery. How do we identify? By this 90-degree turn which is going, and from that posteriorly here we are able to see it is running, and where it is ending, this is the fistula site which is seen here, and the fistula is ending as the vein. This is the vein we are able to see, vein of Galen and straight sinus with multiple cortical veins. These are spot images to understand the anatomy better. So here we are able to see the middle meningeal artery which is going and ending into the fistula. This is the site of the fistula, and from the fistula we are able to see the vein of Galen and straight sinus which is getting appreciated, and in delayed venous the dilated cortical veins of the posterior fossa are better appreciated. Other angiographic runs, the right ICA run shows that the rest of the deep venous system, that is the superior sagittal sinus, is directly going and joining the transverse and sigmoid sinus. There is no opacification of the straight sinus. This is a vertebral artery run. This particular feeder which we are seeing is the posterior meningeal artery. This posterior meningeal artery arises from the vertebral artery. This also goes and supplies the dural AV fistula. So to summarize, this is a dural AV fistula which is located at the Tentorium Cerebelli with multiple arterial feeders, namely the middle meningeal artery from the internal maxillary artery, posterior meningeal artery from the vertebral artery, transosseous feeders, namely the mastoid branch from the occipital artery. There is no nidus suggestive of a fistula rather than an avium, with venous drainage into the vein of Galen which is isolated, and multiple dilated cortical veins into the posterior fossa. Now would be a time to revise the intracranial dural AV fistula classification, namely the Borden classification and Cognate classification. Borden classification is a much simpler classification when compared to the Cognate. Both these classifications take the most important thing to be the deciding factor is the venous drainage. It's not the artery, it is not the fistula. How many arteries, those things do not come into play. What happens to the venous drainage? This is because the entire course or what is going to happen is dependent upon the pressure that the venous system is going to experience. So if the entire artery is going to shunt into the dural sinus, it's a better normal anatomical kind of a pathway. But if it is going to shunt into the cortical veins which are much smaller in diameter, then it gets classified into aggressive kind of a pathology. So one is only dural sinus, there is no cortical venous drainage. Two is you have a dural sinus drainage as well as a cortical venous drainage. In three, there is purely cortical venous drainage. There is no dural sinus drainage at all. A more complicated is the Cognate classification, in which not only the venous drainage but the pattern of flow in this sinus, whether it is antegrade, the normal kind of a flow, or because of a stenosis or obstruction there is a retrograde flow, and what is the diameter of the cortical vein, whether it is dilated or it is normal. Based on that it is classified from 1 to 5. I'll just discuss about Borden alone. Here it's simpler to understand. There is an artery, there is a fistula, there is a venous drainage. In the AV fistula, what happens? This is a normal way in which blood runs from the transverse sinus into sigmoid sinus and down. So if it has an antegrade kind of a pathway, it is called as type 1 fistula. Type 2, what happens is there is an artery, but instead of going downstream, why it doesn't go downstream is because of a stenosis or occlusion which is there, which prevents it from growing, and because of that the arterialized flow, which is shown as red, is going and reflexing back retrogradely. It can go into the dural venous sinus or it can go into the cortical vein, in which case the cortical veins get dilated as in this patient. Third is even more a serious kind of a thing, in which the artery directly goes into the cortical veins. There is no direct communication with the sinus. It is totally obstructed at this level. So all the arteries directly go into the cortical vein. Eventually the cortical veins go and drain into the sinus. So this is type 3 Borden. So when we discuss about dural AV fistula, there are certain features which gets labeled as aggressive features. What do we mean by aggressive features? What happens due to dural AV fistula? What is the natural history? Some of these patients can be stable for quite a period of time, but those patients who have these aggressive features will eventually need some kind of a treatment to be done. They cannot be kept on conservative treatment due to the associated risk factors. That is, factors such as that these patients can develop venous infarcts or recurrent hemorrhages which can occur, both of which has been documented in this patient by the hemocytosis as well as by the venous infarcts which we saw on the MRI images. So what contributes to these aggressive features? One is cortical venous drainage. So that is simple to understand. If the instead of going through a large caliber vein, if it is going through the cortical vein, it is going to rupture and it is going to bleed. So if you document a cortical venous drainage, then that gets labeled as an aggressive feature. If you see a galenic deep venous drainage, that is the venous drainage has a vein of Galen component, then again it is a high feature, it is an aggressive feature because it also supplies the important structures of the brain. And if there is an aneurysmal dilatation, needless to say that these can rupture at any point of time and they are handling high pressure which they are not supposed to handle. So that is one of the reasons why all these complications occur. Third and the last important thing is tentorial fistula. That is, if these fistulas are at the tentorium of the cerebelli, then they are known to have aggressive pathology or aggressive course of nature over a period of time. So all these things were observed in this particular patient. So to summarize the final diagnosis, this is a tentorium cerebelli dural AV fistula with middle and posterior meningeal artery feeders, also a few transosseous feeders from the occipital artery. The vein of Galen was isolated from the rest of the dural venous system. The cortical veins were dilated and it gets classified as Borden type 3 with both the complications, that is superficial hemocirrhosis as well as venous hypertension with resultant venous infarcts noted. So this is a combination of MRI as well as DSA which is able to help us in attaining the final diagnosis in this patient. So what was done? Onyx embolization. I'm not going to the intricacies of onyx embolization. Basically into the middle meningeal artery a microcatheter is taken, and once we reach the fistula, this is where the fistula is, and through the fistula, once we reach the fistula, we start injecting onyx. Onyx is basically a glue kind of a thing, basically something which blocks the entire blood vessel. So the entire artery as well as the fistula as well as the vein gets totally blocked. The important thing that we try to do is to block the venous outflow tract. That is, if you block just the artery, it's not going to help. As we see, it will be taking feeders from the posterior meningeal artery or from other feeders also. So we need to occlude the venous component of the fistula for the entire dural AV fistula to go away in the patient. So which is what was done in this particular patient, and here we can see post onyx embolization there is no opacification of the dural AV fistula. The subtracted image here shows the ONYX CAST. I'll show the ONYX CAST better in the next image. This is the ONYX CAST. It is better seen in this image. Here we are able to see whatever is seen as black is all where the ONYX has percolated. So through the middle meningeal artery, this is the petrosquamosal branch. This is run here distally. The microcatheter was lodged here. Longer route, but easier to go when compared to the transosseous, because this part of the skull cannot be negotiated if you go to the occipital artery. So it appears to be a smaller route. The longer middle meningeal artery route was taken, and once the microcatheter was reached here, ONYX was injected. ONYX around 1.5 to 2 ml was injected. So here we are able to see the entire proximal part of the vein is all getting blocked by the ONYX. The ONYX goes and blocks the entire vein, then the fistula, and once the fistula gets blocked, we are able to see all the arterial feeders. These are varial arterial feeders which are leading to the dural AV fistula. So this is the posterior meningeal artery, this is the middle meningeal artery, everything gets taken up. I'd like to concentrate on the lateral view alone. So here I have put a zoomed out view of the lateral view just to discuss about the etiopathogenesis. If you take the etiopathogenesis of dural AV fistula, two accepted theories is that all these fistulas are already existing in patient. Basically, these are physiological shunts which are already present in the patient, and now it is getting opened up. Other thing is, no, it is not because of physiological shunts. Because of the arterial venous fistula, the arterial supply is not reaching the brain, and there is a hypoperfusion which is occurring, which is leading to recruitment of new blood vessels. So one theory states that it is physiological shunts, the other one says that it is neoangiogenesis, new blood vessels are seen. At least in this patient we can confirm the theory. This is an image which I have taken from this article called Middle Meningeal Artery Normal and Variations. Here you can see this is a normal physiological variations which are seen. This is a middle meningeal artery which is running here. It is going and joining the various branches. So this particular branch which we are able to see here running is the posterior meningeal artery, which is a branch of the vertebral artery. That is this particular structure, this black line, you can see it. It has the same morphology like this. Close to the skull base, a line which is running here. These two branches, this is basically the mastoid branch which is occurring from the occipital artery. That is also seen here. This is the occipital artery mastoid branches. This is a jugular branch which is coming from the ascending pharyngeal, which proximal part of it is seen. So at least in this patient, this AV fistula is because of pre-existing middle meningeal artery anastomotic branches which are opened. So why have they opened? Because of venous thrombosis. The entire venous sinus would have been thrombosed, or there would have been a history of trauma, but we were not able to elicit either of these history in this patient, which has led to increase in pressure leading to opening up of these physiological shunts. So this cast shows which are the arteries which have been taken out, which is the vein which has been taken out, and what has happened to the fistula. Post-procedure MRA, here we are able to see the vein of Galen instead of being black, now it has become hypogenic. Onyx has become has deposited into the vein, so instead of being white, now this appears black. Pre-procedure, post-procedure MRV images and MRI images have been put on tat comparison. Here we are able to see the vein of Galen has been totally removed out. This is a venous outflow. Congested cortical veins are all not visualized as compared to the previous MR venogram images. Here again we are able to see the fistula is no more seen here. Even the middle meningeal artery which is seen here is not present. The occipital artery is still present, but however the fistula is not seen, as well as the vein of Galen and straight sinus which is not seen. So this was a 100% curative embolization which was done, which is again not ideally possible in all patients. So this patient presented with diplopia, and day 1 post procedure the patient had completed recovery of vision. He was not able to see properly. Sensory neural hearing loss persists for a long time, and this is because of that hemosiderin deposition which has occurred, leading to SNHL. So basically we have discussed about dural AV fistula, social hemosiderosis, middle and posterior meningeal arteries versus transosseous feeders, why we prefer middle meningeal arteries, what is the classification of dural AV fistulas, about onyx embolization and etiopathogenesis. Thank you.